This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to go over static manual release of the deep cervical extensors. That's the semispinalis, capitis, and cervicus, as well as the transversal spinalis, multifidi, and rotatories muscles. I'm going to have my friend Melissa come out. She's going to help me demonstrate. Now we're going to go through the same four-step process we've gone through with all of our static manual release techniques. The first being, how do we differentiate and palpate these tissues? Well, to palpate these tissues is actually not that hard. If you have somebody extend their head, and I mean really tilt their head back against some resistance, you'll see these two columns, or at least feel these two columns of muscle pop up on either side of the spinous process. What those two columns of muscles are is literally the semispinalis contracting and bulging up a little bit, as well as the transversal spinalis muscles, those rotatories and multifidi muscle underneath it contracting and bulging up underneath them, so that we push these two big columns of muscles up into my fairly thin upper trap. All right, so we know where these columns of muscles are. We know where these muscles are as a group. The question then becomes, how do we differentiate them? How do I know that I'm on a rotatories muscle versus my semispinalis muscle? The truth is, we probably can't differentiate. We probably can't be accurate and reliable without palpation, but we might not have to be, right? If we're just trying to correct movement, if we're going back and putting our thinking caps on with, my assessment showed that I had a restriction in X movement. Maybe it's rotation to the left or extension, or maybe it's a combination of flexion and rotation, right? We would need to show that these muscles do different things if we really needed to differentiate them. And actually, all of these muscles have a similar obliquity. They all go from superior medial to inferior lateral. Now, they have different fiber angles, but they all somewhat contribute to extension because they're on the posterior side of the neck. Since they're on the side of the spinous process, they all contribute to a little ipsilateral flexion. And since they have this obliquity, they all contribute to just a little bit of contralateral rotation. So all of these muscles do the same thing. It's probably not that important for us to have to know exactly how I'm going to get on semispinalis capitis or how I'm going to get on my multifidi at C3, C4. I just need to know that I am on this column of muscle at the right segment, or at least I've found the tissue density that's restricting me. Now, second step, is there anything close to these tissues that could be insulted, abraded, injured by compression? Well, I'm posterior to the transverse processes, right? I'm posterior on the cervical spine. Most of the sensitive stuff is on the anterior side of the cervical spine, so chances are I can't really injure a nerve or injure a vessel. All I can do is press here, and trust me, if you press hard enough, you can mess somebody up pretty bad just by bruising and damaging some muscle tissue. But if I'm careful and I only press as hard as I need to, I shouldn't run into any issues. Okay, so step 3, what about trigger points? Well, trigger points occur in the middle of the muscle bellies of these muscles. Problem: these muscles are tiny little muscles that run from segment to segment and are segmentally innervated, which means we can have trigger points between any segment. So you don't really have to memorize where a trigger point is. That's not necessarily going to be helpful, but you may have to search the entire cervical spine and maybe even going all the way down to the mid-thoracic spine if there happens to be trigger points in the semispinalis muscles, which originate way down here, all the way down to like T6. Number 4, positioning, right? So how do I get us positioned in a way where I can hold the technique long enough to get a release and my client or patient is comfortable enough to relax to allow a release to happen? Well, honestly, sitting isn't the greatest way to go, but you might be able to get away with having the patient face away from you, doing our forehead headlock position, like so. I think I showed you guys that in a previous video. And I could use my thumb, probably best in a downward direction, this way, to strum these tissues. Right, so these tissues run kind of like this to like this. I'm going to strum kind of downward as I maybe flex a little bit. Maybe I'll contralaterally rotate to lengthen, or maybe I'll shorten up a little bit to get the traps out of the way. I can definitely control a little bit this way. But I got to tell you, overall, guys, standing with your patient and sitting isn't really an easy way to do these techniques. I think probably the best way to do these techniques is in supine. Let me have you lay down. I think you guys have seen a lot of neck massage, maybe neck manual techniques, cervical, neck, static release techniques by various manual practitioners and various professions, and they all kind of do this thing. Well, chances are they're on the cervical extensors, and as long as there's a good reason for them to be releasing the cervical extensors, we're on the right track. This is actually a very comfortable position to do this, because I can just let my hands relax into that natural curled position that our hands kind of get into, and I can let the weight of Melissa's head do all the work. Now, of course, I need to do my strumming here, taking some short strokes so I don't take so much skin with me. I'm going to be kind of going from medial to lateral as I do these short strokes from inferior to superior. So I'm just kind of going through this way. To see where my densest fascicles are. And I got a couple good ones right there. Alright, so once I find a good fascicle here, I can look for any nodules within that fascicle. And then I'm just going to hold this position until I get a release. Once I get a release, I can continue searching. Remember, with these muscles, since we're not just dealing with a single muscle, since we are dealing with a group of muscles, it's probably worth continuing your search to make sure you clear the entire deep cervical extensor group from mid-thoracic spine all the way up to the occiput. How's that feel?
Better.
Good. So then I would continue on, right? And I could even get down in here, right? I got to work my hands underneath a little bit, but right, and maybe right in here I start feeling some stuff. It's a little harder in your hands in this position, and actually the lower fibers, you might be able to go back to that seated position and get better leverage and be more comfortable as the practitioner. Since I have large hands, I still find that this technique is a little bit more comfortable for me. Stay tuned for the close-up recap. So this is our close-up recap of deep cervical extensor release. That's my semispinalis multifidi and rotatories muscles. I wanted to show you guys close-up what that column of muscle looks like. So Melissa, go ahead and extend your head. All right, you guys see that pop up right there? Oh yeah, that's all the deep cervical extensors right there. So that's a good start for knowing where to put your hands. Now these muscles have a slight obliquity from like ear to shoulder, right? So that's superior medial to inferior lateral. So as I stroke, I want to stroke from lateral to medial, superior to inferior, so in opposition to that fiber direction, so that I stroke across those fibers. And I'm just going to gently kind of stroke across those fibers with both hands until I find some tight fascicles, some dense fascicles, and then I can move medial and lateral to kind of narrow in on the tightest part of those fascicles, the nodule, trigger point, point of hyperactivity, and then I can just use that kind of curled finger position and the weight of Melissa's head to add a little compression until I get a nice release, and then I can reassess. So once again, guys, I'll turn Melissa's head here a little bit, which is not necessarily something I would suggest for this technique, but all I was doing was stroking this way in towards the spinous process as I moved superior to inferior. Right? Wait until I found the tightest fascicles. Once I found some tight fascicles, then I can move medial and lateral, superior to inferior, really try to narrow in to any sort of knot. And then I'm just using the weight of Melissa's head to apply compression to this kind of curled finger hand position, and I can wait for a release. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, one-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.